Block simulation 38. Same process, fresh set. Read the command first, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Clock starts now. Which statement about sodium reabsorption is correct? A renal physiologist studies how sodium is handled along the nephron segments. Read the command. Which sodium handling statement is correct? Proximal about 65%, isosmotic, thick ascending limb about 25%, sodium potassium 2-cal or loop, distal about 5%, sodium chloride or thiazide, collecting duct about 3%, ENaC or aldosterone. Sodium is reabsorbed all along the nephron, but in characteristic proportions at each segment, and each is a drug target. The proximal convoluted tubule reabsorbs the most sodium, about 65% isosmotically. Water follows, coupled to the reabsorption of glucose, amino acids, and bicarbonate, and it's where carbonic anhydrase or acetazolamide and SGLT2 act. The thick ascending limb of the loop of Henle reabsorbs about 25% via the sodium potassium 2-Cl cotransporter, the target of loop diuretics, furosemide. The correct answer is C. The distal convoluted tubule reabsorbs about 5% via the sodium chloride cotransporter, the target of thiazide diuretics. The collecting duct, principal cells, reabsorbs the final about 3% through the epithelial sodium channel, ENaC, under the control of aldosterone. This is the fine-tuning site for sodium balance and the target of potassium-sparing diuretics, amiloride blocks ENaC. Spironolactone blocks the aldosterone receptor. So most sodium is reclaimed proximally, bulk, while the distal segments and collecting duct fine tune it under hormonal control. The proximal 65%, loop 25%, distal 5%, collecting duct 3% scheme with its diuretic targets is correct. What is the diagnosis, the stroke mechanism, and the management principles? A 72-year-old with hypertension presents with palpitations and an irregular pulse. ECG shows no discrete P waves and an irregular rhythm. He is at risk for stroke. Read the command, diagnosis, stroke mechanism, management. Irregular, no P waves, stroke risk, atrial fibrillation. Atrial stasis leads to thrombus, leads to embolic stroke. Rate or rhythm control plus anticoagulation. This is atrial fibrillation, AF, the most common sustained arrhythmia. Disorganized, chaotic electrical activity in the atria replaces coordinated contraction. So the ECG shows no discrete P waves and an irregular ventricular rhythm. The AV node conducts impulses erratically. Risk factors include hypertension, age, heart failure, valvular disease, hyperthyroidism, and alcohol. The correct answer is A. The high-yield consequence is the stroke mechanism. Because the atria do not contract effectively, blood stagnates, especially in the left-atrial appendages, forming a thrombus that can embolize to the brain, causing a cardioembolic stroke, a major cause of morbidity. Management has two arms. One, controlling the arrhythmia. Rate control, beta blockers, non-dihydropyridine calcium channel blockers, digoxin and/or RHY-THIM control, cardioversion, antiarrhythmics, ablation, and 2. Preventing stroke with anticoagulation, warfarin or dox with the decision guided by the CHA, 2DS2, VAS score. The irregular no, P-wave rhythm with embolic stroke risk, score. The irregular with embolic stroke requiring anticoagulation is atrial fibrillation. Which statement about the lock operon is correct? A biochemistry student studies how E. coli regulates the genes for lactose metabolism, the lock operon. Read the command, which lock operon statement is correct. Lactose, allolactose, inactivates repressor, leads to ON. Low glucose leads to increased CAM, leads to CAP enhances. Max with high lactose plus low glucose. High glucose is catabolite repression. The LAC operon in E. coli is the classic model of prokaryotic gene regulation. It lets the bacterium make lactose metabolizing enzymes only when lactose is present and glucose, the preferred fuel, is scarce. It is controlled by TW inputs. First, Negative control by the repressor. Normally the lac repressor binds the operator and blocks transcription. When lactose is present, its isomer, a low lactose, binds and inactivates the repressor. Releasing it leads to transcription can proceed, the on switch. The correct answer is C. Second, positive control by catabolite glucose status. This works through CAMP and the catabolite activator protein, CAP. When glucose is LAU, CAMP levels rise. CAMP binds CAP, and the CAMP-CAP complex binds the promoter and strongly enhances transcription. When glucose is hit range, CAMP is low, CAP is inactive, and transcription stays low. This is catabolic repression. The cell prefers glucose. So maximal lac operon expression requires both conditions, HIC-AH lactose, repressor off, and low glucose, CAMP-AAP on. The lactose removes, repressor plus low glucose, CAMP. KP enhances logic is correct. Which statement about the intrinsic muscles of the hand and their innervation is correct? A patient with a hand injury has weakness of intrinsic hand muscles. Read the command. Which hand intrinsic innervation statement is correct? Ulnar is most intrinsics, inter-OC, medial two lumbricals, hypothenar, adductor, pollicis. Median is thenar plus lateral two lumbricals, loaf. The intrinsic muscles of the hand are split between two nerves, and this division is high yield. The ULNR nerve supplies most of them. AL of the interosei, dorsal and palmar, abduction or adduction of digits, the medial two lumbricals to digits 4 and 5, the hip thenar muscles, abductor digiti minimi, etc., and the adductor pollicis. So an ulnar nerve lesion causes weakness of finger abduction or adduction and the ulnar claw. The correct answer is E. The median nerve, via its recurrent and other branches, supplies a smaller set, remembered by loaf, the lateral two lumbricals to digits 2 and 3, the opponent's pollicis, the abductor pollicis brevis, and the flexor pollicis brevis, essentially the DNR muscles plus the radial lumbricals. So median nerve injury, e.g. carpal tunnel, causes thenar wasting and loss of thumb opposition or abduction. The radial nerve supplies no intrinsic hand muscles, it serves the forearm extensors. The ulnar supplies most, inter-OC or hypothenar or adductor, and median supplies. Loaf, thenar, division is correct. What is the diagnosis and the mechanism? A 60-year-old with long-standing, poorly controlled hypertension has slowly worsening renal function with mild proteinuria. Biopsy shows arteriolar wall thickening with hyaline deposits, hyaline arteriolosclerosis, and small scarred kidneys with a finely granular surface. Read the command, diagnosis, and mechanism. Long-standing HTN, hyaline arteriolosclerosis, small granular kidneys, slow CKD, hypertensive nephrosclerosis. This is hypertensive nephrosclerosis, benign nephrosclerosis, the chronic renal damage caused by long-standing hypertension. The mechanism, sustained high pressure, injures the renal arterioles, causing hyaline arteriolosclerosis. Thickening and hyaline protein deposition in the walls of the small arterioles, narrowing their lumens. This reduces blood flow, producing chronic ischemic injury to the glomeruli, glomerulosclerosis, and tubules, atrophy, and interstitial fibrosis. The correct answer is B. The result is a slowly progressive chronic kidney disease, usually with only nilled proteinuria and a gradual rise in creatinine. Grossly, the kidneys become small and shrunken with a finely granular, grain leather surface from the diffuse scarring. Hypertension and diabetes are the two leading causes of CKD and ESRD, distinguished from malignant hypertension, which causes hyperplastic onion skin, arteriolosclerosis, and fibrinoid necrosis with acute renal failure. Tight blood pressure control, ACE inhibitors or ARBs are renal protective, slows progression. The hyaline arteriolosclerosis, small granular kidney chronic disease of hypertension is hypertensive nephrosclerosis. Which statement is correct? A physiologist reviews calcium homeostasis. This question targets the integrated actions of PTH, vitamin D, and calcitonin on bone, kidney, and gut. Read the command. Which calcium homeostasis statement is correct? PTH raises Ca bone resorption, renal Ca reabsorption, increased phosphate excretion, increased vitamin D activation leads to gut absorption. Calcitonin lowers Ca, inhibits osteoclasts. This revisits calcium homeostasis as an integrated system. Parathyroid hormone, PTH, is the main minute-to-minute regulator released when serum calcium is low. It raises serum calcium through three coordinated actions. 1. Bone stimulates osteoclastic bone resorption, releasing calcium and phosphate. 2. Kidney increases calcium reabsorption, distal tubule, while increasing phosphate excretion inhibits proximal phosphate reabsorption, so PTH lowers serum phosphate. And 3. Indirectly via vitamin D, PTH stimulates renal 1A-alpha hydroxylase to activate vitamin D. The correct answer is D. ACTI, vitamin D, 125, dihydroxyvitamin D or calcitriol, then acts mainly on the GU, increasing intestinal absorption of both calcium and phosphate, and it also aids bone mineralization and some bone resorption. So PTH and vitamin D work together to raise serum calcium. Calcitonin from thyroid C cells is released when calcium is Hig and modestly lower serum calcium by inhibiting osteoclast. It tones down calcium, though it plays a minor role in humans. Net low calcium leads to PTH, leads to bone or kidney or gut via vitamin D, raised calcium. High calcium leads to calcitonin opposes. The PTH raises calcium with phosphate excretion and calcitonin lowers. Calcium framework is correct. Which antiplatelet drug mechanism pairing is correct? A patient after a coronary stent is on aspirin plus clopidogrel. Another in the cath lab receives abciximab. Read the command. Which antiplatelet mechanism is correct? Aspirin is COX-1, decreased TXA2. Clopidogrel is ADP and P2Y12. Abciximab is GP2B3A. Dipyridamole or cilostazol is PDE inhibitor. The antiplatelet drugs act at different steps of platelet activation or aggregation. Aspirin R readily inhibits cyclooxygenase COX-1, blocking the synthesis of voxane A2, a platelet activator or aggregator, for the platelet's lifetime, about 7-10 days. The P2Y12 ADP receptor, B-Locus, clopidogrel, prasugrel, ticagrelor block the ADP receptor that platelets use to amplify activation and express GP2B3A, clopidogrel, or prasugrel are irreversible. Ticagrelor, reversible. The correct answer is A. The GP2B3 are receptor I inhibitors, ABCI-eximab, eptifibatide, tirofibitide. Tirofibin step of platelet aggregation, the GP2B3A receptor binds fibrinogen to cross-link platelets used acutely in PCI or acute coronary syndromes. DIPY-ridamyl and CI-lostazole inhibit PR-phosphodiesterase, raising platelet cam, also vasodilator inhibit PR-phosphodiesterase, raising platelet cam, also vasodilators. Dual antiplatelet therapy, aspirin plus A, P2Y12 inhibitor, is standard after coronary stenting, so each drug class hits a distinct target: thromboxane, aspirin, ADP receptor, clopidogrel, or GP2B3A, abciximab. The aspirin coax, clopidogrel, ADP, abciximab G, P2B3. A pairings are correct. Which statement is correct? A patient with recurrent gout is managed. This question targets the ACU attack treatment versus chronic urate lowering therapy. Read the command. Which gout management statement is correct? Acute is NSAIDs or colchicine or steroids. Chronic is xanthine oxidase inhibitors, allopurinol or febuxostat or probenecid. Don't change urate lowering during acute attack. This revisits gout from the management angle, which splits cleanly into acute attack treatment and chronic urate lowering. For the ACU chi, gout flare, the red, hot, exquisitely painful joint, classically the first NTP, Podagras, from monosodium urate crystals. Treatment is anti-inflammatory, NSAIDs, e.g., indomethacin, naproxen, colchicine, inhibits microtubules or neutrophil migration or corticosteroids, oral or intraarticular. These relieve inflammation but do not change uric acid levels. The correct answer is D. The Shea-Onic management between attacks for recurrent gout or tophi or high urate lowers the uric acid burden. Xanthine oxidase inhibitors, allopurinol and febuxostat, decrease urate production or block the conversion of hypoxanthine or xanthine to uric acid. No allopurinol also raises levels of azathioprine or 6-menthine oxidase. Uric osurics like probamyxid increase renal urate excretion, avoiding overproducers or stones. The key clinical pearl: do not start or stop urate lowering therapy during an acute attack. Abruptly shifting urate levels can precipitate or prolong the flare. When initiating urate lowering therapy, co-prescribe prophylactic colchicine or NSAI. The acute anti-inflammatory versus chronic urate lowering therapy, co-prescribe prophylactic colchicine or NSAID. The acute anti-inflammatory Everdet lowering therapy during an acute attack. Which organism is responsible? A patient from an endemic region has hypopigmented anesthetic skin patches and thickened peripheral nerves. A biopsy shows acid-fast bacilli. The disease has a tuberculoid form, few bacilli, strong cell-mediated immunity, and a lepromatous form, many bacilli, weak immunity, leonine facies. Read the command. Which organism? Hypopigmented anesthetic patches, thickened nerves, acid-fast, tuberculoid versus lepromatous. Mycobacterium leprae. This is Mycobacterium leprae, the acid-fast bacillus that causes leprosy, Hansen disease. It characteristically affects the cooler parts of the body, the skin and the superficial peripheral nerves, producing hypopigmented, anesthetic, numb, skin lesions and thickened palpable peripheral nerves, with sensory loss leading to unnoticed injuries and deformities. It cannot be grown in vitro cultured experimentally in the 9-banded armadillo and mouse footpads. The correct answer is E. The two ends of the spectrum are determined by the host's immune response. A classic HE1 versus D2 example. Tuberculoid leprosy, a strong CEL-mediated response contains the infection leads to FEW bacilli, limited, well-demarcated, hypopigmented anesthetic patches, granulomas, and a positive lepromin test. Lepromatous leprosy, weak cell, mediated response, T2 predominance, leads to uncontrolled spread with many bacilli, widespread symmetric skin lesions, and the characteristic leonine facies line-like facial thickening. Treatment is multi-drug, dapsone, rifampin, and clofazimine for lepromatous. The acid-fast, cool tissue-loving tuberculoid versus lepromatous organism is Mycobacterium lepromatous. Which statement is correct? A physiologist studies the growth hormone GH-IGF-1 axis. Read the command which GH and IGF-1 statement is correct. GHRH leads to GH, GH direct, anti-insulin, increased glucose, lipolysis, plus indirect, liver IGF-1 leads to growth, somatostatin inhibits, excess leads to gigantism or acromegaly. The growth hormone, or IGF-1 axis, controls body growth and metabolism. The hypothalamus releases GHRH, growth hormone-releasing hormone, which stimulates the anterior pituitary somatotrophs to secrete growth hormone, GH, or somatotropin. Somatostatin from the hypothalamus inhibits GH release. GH is also released in pulses, highest during deep sleep and stimulated by exercise, highest during deep sleep and stimulated by exercise, hypoglycemia, and stress. The correct answer is C. GH has direct and indirect effects. Directly, GH is largely anti-insulin, diabetogenic. It raises blood glucose, decreases peripheral glucose uptake, promotes lipolysis, and increases protein synthesis. Indirectly, and this is the key growth mechanism, GH stimulates the liver and other tissues to produce IGF-1, insulin-like growth factor. 1. Somatomedin C, which is the main mediator of GH's growth, promoting effects, bone, cartilage, muscle. IGF-1 also feeds back to suppress GH. Clinically, EXE-SSGH causes gigantism in children before growth plates close and acromegaly in adults. Deficiency causes short stature or growth failure. The GHRH-GH-IGF-1 axis with GH's anti-insulin direct effects and IGF-1 mediated growth is correct. What is the diagnosis? A 60-year-old is found to have a markedly elevated PLA-TET-TLET count, greater than 1 million butene, on routine labs with occasional thrombosis and bleeding. There is no reactive cause, no iron deficiency, infection, or inflammation. Bone marrow shows increased enlarged megakaryocytes. Many cases carry a JAK2 mutation. Read the command diagnosis. Markedly high platelets, thrombosis or bleeding, large megakaryocytes, JAK2, no reactive cause, essential thrombocythemia. This is essential thrombocythemia, ET, one of the chronic myeloproliferative neoplasms, along with polycythemia vera, primary myelofibrosis, and CML. It is a clonal proliferation of the megakaryocyte lineage, causing massive overproduction of platelets, a markedly elevated platelet count, often greater than 600,000, 1,000 plus. The bone marrow shows increased numbers of large, mature megakaryocytes. The bone marrow shows increased numbers of 1,000 plus. The correct answer is B. A characteristic paradox is that ET predisposes to both thrombosis, the excess platelets clot, strokes, MI, erythromelalgia, burning red hands and feet, and bleeding. The platelets are dysfunctional, and very high counts can cause acquired von Willebrand deficiency. Many cases carry the JAK2 V617F mutation, or CALR or MPL mutations. It is a diagnosis of exclusion. One must rule out reactive thrombocytosis from iron deficiency, infection or inflammation, malignancy, postglenectomy, and other myeloproliferative disorders or CML. Management for high-risk patients includes hydroxyurea and aspirin. The clonal megakaryocyte or platelet overproduction with JAK2 and thrombosis plus bleeding is essential thrombocythemia. Which statement about brainstem cranial nerve nuclei is correct? A neurologist localizes a brainstem lesion by which cranial nerve nuclei are affected. Read the command. Which brainstem CN nuclei statement is correct? Midbrain is 3, 4. Pons is 5, 6, 7, 8. Medulla is 9, 10, 12. XI upper core. The cranial nerve nuclei are arranged in the brainstem in a rostral to caudal order that allows lesion localization. The MID brain contains the nuclei of CN3, oculomotor, and CN4, trochlear. The pons contains the nuclei of CN5, trigeminal, CN6, abducens, CN7, facial, and CN8, vestibulocochlear. The medulla contains the nuclei of CN9, glossopharyngeal, CN10, vagus, and CN12, hypoglossal, with CN11, accessory, arising from the upper cervical spinal cord. The correct answer is E. The useful memory aid is the rule of 4s. There are 4 cranial nerves in each of the midbrain, while 2, 3, IV, pons, VV8, and medulla, IXTI, regions when grouped, and the cranial nerves that deviate evenly into 12, CN3, IV, VICI, are the medial motor nuclei, running near the midline, while the others sit more laterally. This organization explains the classic cross brainstem syndromes. A lesion produces IPS-lateral cranial nerve signs from the nucleus or fascicle, plus contralateral body signs from the long tracts, e.g. medial medullary syndrome, CN12, plus contralateral hemiparesis. The midbrain, 3, 4, pons, 5, 6, 7, 8, medulla 9, 10, 12 arrangement is correct. Which gross motor milestone is matched correctly to its approximate age? A pediatrician assesses development. Read the command. Which milestone age pairing is correct? Head control about 2 mo, rolls about 4-6 mo, sits about 6 mo, crawls about 9 mo, pulls to stand about 9-12 mo, walks about 12 mo, runs about 18 mo, stares about 2 IR. Developmental milestones are high yield, and the gross motor sequence is a common test point. Approximate ages: head control holds head up by about 2 months, ROLs over around 4-6 months. SITs unsupported around 6 months, Carl's around 8-9 months, calls to stand and cruises, walks holding furniture around 9-12 months. Correct answer is B. Continuing, walks independently around 12 months, range about 9-15 months, runs around 18 months, walks upstairs and kicks a ball around 2 years, and pedals a tricycle around 3 years. For quick reference, milestones also span social, language, and fine motor domains, e.g., social smile about 2 months, stranger anxiety about 9 months, first words about 12 months, 2-word phrases about 2 years. The clinical use is screening. Significant delay beyond the expected range warrants evaluation. The sits at 6 months, walks at 12 months, runs at 12 months, runs at 12 months, runs at 18 months. Gross motor sequence is correct. Which blotting or PCR technique is matched correctly? A researcher uses molecular lab techniques to detect a specific DNA sequence, an RNA transcript, and a protein. Read the command which blotting or PCR technique matches. Southern is DNA, northern is RNA, western is protein. PCR amplifies DNA. SNOW drop. The blotting techniques detect different macromolecules and the mnemonic SNOW drop maps them. Southern is DNA, northern is RNA, western is protein. S and N or W for the techniques line up with D and R or P for the targets. Southern blot detects a specific DNA sequence. DNA is cut, separated by gel electrophoresis, transferred to a membrane, and probed with a labeled complementary DNA probe. Northern blot is the same idea but detects RNA, e.g. to measure gene expression or mRNA levels. The correct answer is C. Western blot detects a specific protein. Proteins are separated by electrophoresis, transferred, and probed with antibodies, used, for example, as a confirmatory HIV test historically. PCR, polymerase chain reaction, amplifies a specific DNA sequence exponentially using primers, heat cycling, and DNA polymerase. RT-PCR amplifies RNA after reverse transcription. qPCR quantifies. ELISA, enzyme-linked immunosorbent assay, uses antibodies to detect or quantify a specific antigen or antibody, e.g. screening tests. So southern DNA, northern RNA, western protein, PCR amplifies DNA. The SNOW drop blotting assignments are correct. Which esophageal cancer type is this, and what is the contrast with the other type? A 60-year-old man with a long history of smoking and alcohol use has progressive dysphagia, solids then liquids, and weight loss. The tumor is in the middle third of the esophagus. Read the command, which esophageal cancer type, and contrast. Smoking or alcohol, middle third, dysphagia. Squamous cell carcinoma versus adenocarcinoma, lower third, Barrett and GERD. This is squamous cell carcinoma, SCC, of the esophagus. It is classically associated with the smoking and alcohol. The major risk factors, synergistic as well as very hot beverages, nitrosamines, and achalasia or caustic strictures. It typically arises in the upper and middle thirds of the esophagus, lined by squamous epithelium. It is the most common esophageal cancer worldwide. The correct answer is A. The high-yield contrast is with esophageal adenocarcinoma, the other major type, which arises in the lower third near the gastroesophageal junction from Barrett esophagus, intestinal metaplasia due to chronic GERD or reflux and obesity, and is now the most common esophageal cancer in the United States and Western countries. Both types present similarly progressive dysphagia, first to solids, then liquids, weight loss, odynophagia, and often a poor prognosis, late presentation. So, middle or upper third plus, smoking or alcohol is squamous. Lower third plus, Barrett and GERD is adenocarcinoma. The smoking or alcohol related, middle third squamous cell carcinoma is the answer. Which statement is correct? A physiologist studies the peripheral chemoreceptors and the control of ventilation. Read the command, which peripheral chemoreceptor statement is correct? Peripheral, carotid, or aortic bodies sense low PaO2, less than 60, high CO2, low pH, leads to hypoxic drive. Central, medulla, sense CSF pH or CO2, main driver. Ventilation is controlled by two sets of chemoreceptors. The peripheral chemoreceptors, the carotid bodies at the carotid bifurcation via CN9 and aortic bodies via CN10 are the ones that sense arterial oxygen. They are stimulated by a low arterial PaO2, importantly, only when it drops below about 60 millimeters of mercury, the steep part of the response, and also by IH, PaCO2, and low pH hydrogen. They drive the hypoxic D drive to breathe. The correct answer is B. The central chemoreceptors in the medulla are actually the primary moment-to-moment regulators of ventilation. They sense the pH of the cerebrospinal fluid, which reflects arterial CO2. CO2 crosses the blood-brain barrier and forms hydrogen in the CSF, so rising CO2 is the main normal stimulus to breathe. They do not sense O2 directly. The clinical pearl in a chronic CO2 retainer, severe COPD, whose central drive is blunted to chronically high CO2, breathing may depend more on the peripheral H-hypoxic drive, so giving high flow, OxyGN can reduce that drive and worsen hypoventilation or CO2 retention, give controlled O2. The peripheral O2 or hypoxic drive versus central. CO2 distinction is correct. Which statement is correct? A postmenopausal woman is screened for osteoporosis. This question targets the risk factors, screening and treatment, not just the definition. Read the command. Which osteoporosis risk or treatment statement is correct? Risk is estrogen deficiency or age or steroids or smoking or low calcium. D. Dexa-T at most minus 2.5. Treat Ka+D plus bisphosphonates, first line. This revisits osteoporosis from the risk or screening or treatment angle. Osteoporosis is reduced bone mass with normal mineralization, leading to fragile bones and fragility, fractures, vertebral compression, hip, wrist, or coalesce. The major risk factors: postmenopausal, estrogen deficiency, estrogen normally restrains osteoclasts, its loss accelerates resorption, advancing AGE, low body weight or white or Asian ethnicity, smoking and excess alcohol, corticosteroid use, and other secondary causes, hyperthyroidism, hyperparathyroidism, physical inactivity, and low calcium and vitamin D intake. The correct answer is D. Screening is by DEXA, dual energy X-ray absorptiometry, bone densitometry, with the T-score, a T-score of minus 2.5 or lower defines osteoporosis. Between minus 1 and minus 2.5 is osteopenia. Note that routine labs, calcium phosphate, alkaline phosphatase, are typically normal in primary osteoporosis. Treatment: ensure adequate calcium and vitamin D, weight-bearing exercise, smoking or alcohol cessation, and pharmacologic therapy, bisphosphonates, alendronate, etc. are first line. They inhibit osteoclasts. Watch for esophagitis and osteonecrosis of the jaw. Others: denosumab, anti-rankle, teriparatide, PTH analog, anabolic, anti-rankle, teriparatide, PTH analog, anabolic, and raloxifene, SERM. The estrogen deficiency or steroid risk factors, Dexa-T at most minus 2.5 screening, and bisphosphonate treatment is correct. Which statement is correct? A patient started on atorvastatin for high LDL is monitored. This question targets statin side effects and how other lipid drugs compare. Read the command. With statin side effect, the lipid drug statement is correct. Statins decrease LDL, myopathy, or hepatotox. Fibrates decrease TG. Niacin increase HDL, flush. Ezetimibe blocks absorption. PCSK9 decrease LDL. Resins decrease LDL. This revisits statins from the side effect or comparison angle. Statins, HMG-CoA reductase inhibitors, are the most effective drugs for lowering LDL cholesterol. They inhibit cholesterol synthesis, upregulating hepatic LDL receptors. They also modestly raise HDL and lower triglycerides and reduce cardiovascular events. Their key side effects are myopathy, ranging from myalgias to rarely Rh abdomyolysis check CK. Risk is higher when combined with fibrates, especially gemfibrozil or with C-CYP inhibitors, and hepatotoxicity, transaminase elevations. Monitor LFTs. The correct answer is A. The comparison with other lipid drugs is high yield. Fibrates, gemfibrozil, fenofibrate, PPA alpha agonists, lower triglyceridemia or hyperuricemia, risk of myopathy with statins and gallstones. Nasine raises HDL the most and lowers LDL and TGE side effect, cutaneous flushing mediated by prostaglandins, reduced by aspirin, also hyperglycemia mediated by prostaglandins, reduced by aspirin, also hyperglycemia or hyperuricemia. Ezetimibe blocks intestinal cholesterol absorption, lowers LDL, often added to statins. PCSK9 inhibitors, evolocumab, strongly lower LDL, increase LDL receptor recycling. Bile acid resins, cholestyramine, lower LDL, GI upset, bind other drugs or vitamins. The statin LDL, lowering with myopathy or hepatotoxicity, and the other drug roles is correct. Which virus and family are responsible? A traveler returns from Southeast Asia with high fever, severe headache, retroorbital pain, severe myalgias or arthralgias, breakbone fever, and a rash. Labs show thrombocytopenia. A second infection can cause hemorrhagic fever or shock. The virus is mosquito-borne. Read the command. Which virus and family? Breakbone fever, retroorbital pain, thrombocytopenia, mosquito-borne, hemorrhagic on second infection, dengue, flavivirus. This is dengue, caused by the dengue virus. A flavivirus envelope positive sense single-stranded RNA like yellow fever, Zika, West Nile, and hepatitis C. It is transmitted by Aedes mosquitoes, Aedes aegypti, in tropical or subtropical regions. Classic dengue fever presents with high fever, severe headache with retroorbital pain, intense myalgias and arthralgias, the breakbone fever, a rash, and thrombocytopenia with leukopenia. The correct answer is D. The high-yield danger is the second infection. Dengue has 4 serotypes. Infection with one gives lifelong immunity to that serotype, but not the others. A subsequent infection with a different serotype can paradoxically cause more severe disease, dengue hemorrhagic fever, and dengue shock syndrome, plasma leakage, hemorrhage, shock, via antibody-dependent. Enhancement, non-neutralizing antibodies from the first infection facilitate viral entry. Management is supportive fluids. Avoid aspirin or NSAIDs, bleeding risk. It is in the same flavivirus family as yellow fever and Zika. The Aedes transmitted breakbone fever flavivirus with hemorrhagic risk on reinfection is dengue. Which statement about antibody functions is correct? An immunology student studies the effector functions of antibodies once they bind antigen. Read the command. Which antibody function statement is correct? Neutralization, opsonization, IgG, complement, IgG, complement, IgG, IgG-NK, IgE eosinophils, IgEG abundant or placenta, IgA mucosal. Once antibodies bind their antigen, they carry out several effector functions and different isotypes specialize. Neutralization, antibodies coat and block pathogens or toxins from binding or entering host cells, important for viruses and exotoxins. IgG and IgA are key, e.g. mucosal EGA. Opsonization, IgG coats a pathogen, and phagocytes with Fc receptors. Recognize the antibody Fc leads to enhanced phagocytosis. IgG is the main opsonizing antibody. C3 also opsonizes. The correct answer is E, complement. Activation, classical pathway, antibody bound to antigen triggers C1, leads to the cascade, leads to membrane attack complex and opsonins. EGM is the most efficient complement activator. Its pentamer provides many binding sites, followed by IgG, antibody, dependent cellular, cytotoxicity, ADCC, IgG flags target cells for NK cells to kill, and IgE arms eosinophils against parasites and mediates type 1 hypersensitivity or allergy via mast cells. The isotypes also differ. IgM is first or acute response and complement. IgG is most abundant, crosses the placenta, neonatal immunity, opsonization, neonatal immunity, opsonization. IgA is mucosal or secretory. IgE is allergy or parasites. IgD is naive, B cells. The neutralization or opsonization or complement or ADCC functions with their isotype specialization are correct. Block 38 is done. Let's review the 5 biggest traps from this block. Trap 1. The proximal tubule reabsorbs most sodium, about 65%. The diuretics hit the latest segments. Loop diuretics at the thick ascending limb, thiazides at the distal tubule, and aldosterone or potassium sparing at the collecting duct, the fine-tuning site. Trap 2. PTH raises serum calcium through bone, kidney, and gut, but it lowers serum phosphate by dumping it in the urine. It activates vitamin D, which then boosts gut absorption of both calcium and phosphate. Calcitonin opposes PTH. Trap 3. Treat the acute gout flare with anti-inflammatories, NSAIDs, colchicine, or steroids. Lower urate chronically with allopurinol or febuxostat, and don't start or stop urate lowering therapy during an acute attack. Trap 4. Snow W drop. Southern blot detects DNA, northern detects RNA, western detects protein with antibodies. PCR amplifies DNA. Match the technique to its target. Trap 5. Peripheral chemoreceptors in the carotid and aortic bodies sense low oxygen, the hypoxic drive. Central chemoreceptors in the medulla sense CO2 through CSF pH and are the main driver. That's why too much oxygen can blunt a chronic retainer's drive to breathe. 38 blocks, 760 questions. Train process, not memorization. StepLogic, learn how to think, not memorize.